Statin use saves life. There's overwhelming evidence in both a clinical trial world as well as a real world. However, recently we have seen that more and more people are not taking statins who would clearly benefit from it. It's estimated thousands and thousands of lives are being not protected because of people fail to use statins. Looking at the data, it's clear that there is a clear divergence in the reports between clinical trials as well as observational data. Clinical trials shows that statin use is similar in rates of adverse events as compared to placebo. However, in our real life data, mostly these are observational data, where it's been reported as much as 20% of the patients on statins have adverse effects. Unsurprisingly, these increased reports have caused patients to not take statins, who should clearly be on statins, and has started making a dent on a progress of last 3 to 4 decades. Now, more and more lives are lost because people are not using statins and doctors not prescribing because of fear of adverse events. These adverse events are those which are non-life-threatening. These are pains and aches which are real for the patients, but there's no clear causation, mainly because we do not have any evidence in clinical trial data that these statins actually increases the risk to that extent. Question is why we did this trial, and as I told you earlier, there's a huge public health importance for this trial because of the fact that potentially thousands and thousands of lives are being wasted because of the controversy which we have about whether statins are associated with increased adverse events which are mostly non-threatening and are related to muscle pains. More so, this controversy has been further stimulated by the fact that MHRA and FDA recently also included erectile dysfunction, cognitive impairment, and sleep disturbance among the list of possible side effects with statin use. This provided us with the opportunity to study all these 4 adverse events using a unique database which is ASCOT-Lipid-Lowering Arm. In this trial, patients were followed up for 3.3 years and were given in a blinded phase either atorvastatin or a placebo. After the end of this trial, which was because of the efficacy of atorvastatin, these patients were further followed up for 2.2 years, but at that point of time, patients were offered a statin use. 2/3 chose to be on statins, whereas 1/3 did not go for statins. However, these patients were followed similarly on other parameters. This trial provided us with an excellent opportunity to study all these 4 adverse events. We looked at this data in a blinded way. Our adjudicators looked at using same definition, blinded to either an allocation of a treatment or a phase of a trial, and looked for those 4 adverse events. Therefore, this methodology provides us a possibility of a study of group of people using same methodology and same definition of assessment in a blinded trial phase as well as observational real-world setting. And what we found was surprising. During the blinded phase, we have shown that people who were on atorvastatin as compared to those on placebo did not have increased risk of muscle-related adverse events. Surprisingly, there was in fact reduction in sleep disturbances, and there was no signal of increase in erectile dysfunction or cognitive impairment. That's very consistent with the previous data from our other clinical trials. Then, same people, when they knew that they were on statins, and those who were not on statins, followed up with the same kind of a protocol, but adjudicated blindly, we found those people who statins reported 41% significant excess in muscle-related adverse events as compared to others. But for other side effects, the signals were as clear as same as was they were in blinded phase, which was a control in itself. And why is that? Why the only muscle increase, reported increase, was there in the people who knew that they were taking statins? And that's what we call is a nocebo effect, because both physicians and the patients know that statin can cause muscle aches, and when they were using this drug, reported more, whereas same patients did not know that they are causing statin was related to either erectile dysfunction or deemed to be related to erectile dysfunction or cognitive impairment and sleep, did not report any excess, and what the results was consistent with blinded phase results. This is clear demonstration of a nocebo effect, which we as a clinicians see in day-to-day life. Our findings are going to impact millions and millions of lives. Doctors now are going to know that there is a real existence of a nocebo effect. They know that real data is that increased adverse events related to muscles are not causally related to statins. They need to think about other causes for their patient. Patients also will know that this is a common problem and it may not be statin related. They will continue with the statins. Hopefully, with that, we will save thousands and thousands of lives. We need to also look at the impact of media and other things on our real lives of patients. Our use of misinformation can cause immense harm to our public health, and that's what again our study shows. Hopefully, with this very good study which we have published in Lancet now, which speaks for itself, we will be able to convince people and other doctors, prescribers, to continue with the statins, or if there are any adverse effects, explore other causes. If not, try to optimize the other statin use, reduced dose and others, but make sure that their patients are persistently taking on statins, and so that they are protected for any adverse outcomes such as stroke or heart attack.